So what happens in case of nephrotic syndrome? Basically, nephrotic syndrome is characterized by massive proteinuria. Okay, so there is massive proteinuria in case of nephrotic syndrome. So when a patient has massive proteinuria, he's going to lose a lot of protein, and particularly it's going to be albumin. Like he's going to lose selectively like albumin too much, so he's going to lose a lot of albumin. Because of that, what happens is that his plasma oncotic pressure goes down. Okay, it goes down. We know that oncotic pressure is necessary to keep the blood inside the vascular compartment. So when the oncotic pressure goes down, the fluid starts to leak out into the interstitial space, and then there is edema. Yeah, that's the first thing. So you're going to see edema which is very generalized. Okay, that is always there. And on the other side, what happens is that there's one more mechanism that also contributes to the formation of edema. That is, whenever the plasma oncotic pressure goes down, as I said, a lot of blood is like basically like fluid part of the blood is going to leave the vascular compartment and into the interstitial tissue. Because of this, the effective circulatory volume is going to decrease. Okay, so when the effective circulatory volume decreases, the GFR also decreases, because blood is not getting perfused to the kidney, because there's not much blood in the vascular compartment in the first place. So the GFR will go down. Okay, since GFR is going down, obviously the amount of filtrate has been formed and the sodium that reaches the distal tubule, everything decreases. So that leads to activation of the RAS system. Okay, when the RAS gets activated, it's going to lead to more sodium and water retention. That again will in turn lead to more generalized edema, because how much ever the body is trying to like take up water, like prevent the water loss to the kidney, whatever the water that is saved by the kidney is not going to stay in the vascular compartment at the end of the day, because he doesn't have protein in the first place. And the next thing that you're going to see is that you're going to see because of the decreased albumin, you're going to see an increased liver activity. And why is this happening? Because the liver is sensing that there's less amount of albumin, and we know albumin is synthesized in the liver. So liver tries to compensate it, but it can't do that. Instead, it produces a lot of other proteins as well. Because of that, there is LDL and cholesterol increase particularly. That is what we call as hyperlipidemia in case of a nephrotic patient. And this hyperlipidemia, there is one more thing also that is told, that this is one way of explaining hyperlipidemia because of increased liver activity. There's one more way of telling why there is hyperlipidemia, is that since a lot of proteins are lost, one of that protein could be this thing, lipoprotein lipase, I think. So when the lipoprotein lipase is also lost, so there is increased level of LDL and cholesterol in the body. And because of this, when you collect a urine sample from a patient who has a nephrotic syndrome, you're going to see a lot of fatty cast. Okay, fatty cast, and this also can be called as old fat bodies. Okay, and basically there's like fat in the urine. Okay, and because of what? Because of hyperlipidemia. And what is the next thing that's going to happen? Basically, we discussed about two things as far as now. That is, you have edema and you have hyperlipidemia. And the third thing is going to be antithrombin. Okay, 3 loss. Because of this loss of antithrombin 3, basically antithrombin 3 is protective against clot formation. So when you want to lose this protein as well, because what is nephrotic syndrome means in the first place, because it's basically massive proteinuria. So you're going to lose a lot of protein, and selectively you're going to lose a lot of albumin, but along with that you're going to lose other protein as well. And one of that protein is going to be antithrombin 3. So antithrombin 3 decreases, so obviously the patient will be predisposed. He'll get predisposed to thrombus formation. Like there's increased risk of thrombus formation. So the patient is in a hypercoagulable state. So there's increased risk of formation of this thing, venous thromboembolism, pulmonary embolism, all these conditions. And what else are you going to see? So because of the last thing that you're going to see is that you're going to lose a lot of immunoglobulins as well. You're going to lose a lot of immunoglobulins. Because of that, what happens is that your immunity goes down. So patient is predisposed to infection because of what? Loss of immunoglobulins. Because immunoglobulins at the end of the day, it's a protein. So you're going to lose immunoglobulins, you're going to get infection. So yeah, that's the thing. So I've told you that you have massive proteinuria. If you want to quantify it in a 24 hours urine sample, you're going to see more than 3.5 grams per day. Okay, per day you're going to see more than 3.5 grams per day. and because of that the urine that you collect is going to be frothy. Okay, it's going to be frothy, and you're going to also see what? Fatty casts.